Gerhard Müller-Schwefe, who not only is a well-recognized pain specialist, widely recognized not only in Europe but internationally. Also, I understood that we share at least three passions. One's for red wine, one's for skiing, and the other one's for golf. So we had a nice dinner together last night, and he will not talk about golf, not about skiing, and not about red wine, but about integrated pain, whether it can save money.
Well, thank you for the nice introduction. Actually, pain is my obsession. It's not my pleasure, it's my obsession. And I've been asked to talk about the question, can integrated pain care save money? This is the key issue. Everybody says, well, we should do more and we can save money if only we do it right. And if I talk to politicians, they always tell us, show me, where is the evidence? Does anybody have figures? And yes, we have figures, and I'm going to share figures with you, how we have to do it and what we have to do to save money. Now, this is just to show you where I'm working. The bank is not owned by us, but we are owned by the bank so far. And just to remind you, back pain is a severe problem. 17 to 25% of the inhabitants are suffering from chronic pain, and 1.8 million patients in Germany are suffering every day from back pain. So it's a severe problem, and it's the most common problem and painful condition in general practice. It's even more frequent in general orthopedic practice. Now, worldwide, it's the major reason for medical treatment, and it's the ICD codes M40 to 54. And the lifetime prevalence is 85%, which means almost everyone has back pain sometime in life. Point prevalence is 40%. At this moment, 40% of the population, probably 40% in this room, maybe even more, are suffering from back pain. And the problem is only 10% of these patients develop a chronic pain condition, and 5% of these severe pain conditions. But 5% of these patients are responsible for 50% of the expenses we spend, and the annual loss is 60,000 working years, not days, 60,000 working years in Germany every year. It's a huge amount and a huge lack. And if you look at the numbers, 48 billion euros spent every year for back pain. That's the amount the German government spent for saving banks after Lehman Brothers broke down 2 years ago. Same amount. We are used to many zeros meanwhile, but it's a huge amount of money. But the really annoying thing is that the majority of that is for sick leave and early retirement. More than 70% is for bad treatment. It's not for the effectivity of the system, and pharmacotherapy is just 1.4%. That's where politicians see the major potential for saving money. But early retirement and sick leave is the major problem. That means the ineffectivity of diagnosis and of treatment is our problem. Now, this is an analysis of one of the big healthcare insurances in Germany, the Technikkasse, and 10% of their total sick leave work inability costs is due to back pain, and the majority is low back pain with 5.3% of the total amount, and you see the distribution of the different diagnoses. This is responsible for lots of costs, and in international comparison, we have good trials and good papers showing that if you look at the outcome, Germany is doing very poorly. Comparing to other countries like US, Sweden, Netherlands, and Denmark, we have the highest rate of early retirement, and this is one of the things it's really worth focusing on. If patients have been off work for 3 months or longer, there is only a 35% likelihood for them to go back to work at all, which means the longer they are off work, the less likely they will go back to time. And this makes very clear. It's not the picture, it's not the MRI, it's not whatsoever. It's the timeline that counts. If we don't have early intervention, we miss the point where to go on. And on the other hand, we have a good spa system. We have many rehabilitation units, probably because our healthcare minister came from an area where they are located. So that's what the Germans prefer, but it's not what is effective. Usually, we go very slowly at the beginning. The patient is with a general practitioner. It's not very well treated. Some OTC drugs probably, and then maybe some X-rays or MRI. And finally, When everything is gone, then we really take money, we do a lot of things, but the time is gone for that. And what we should do is actually change things. We should identify the patients on higher risk and at the early time have many measures taken them from to prevent them from becoming chronic pain patients. Now, this is again the analysis of this insurance. And as you can see, many patients have a spontaneous return to work within 1 week. 30% have a duration of 6 weeks, up to 6 weeks. But if it's longer than that, and that's only 10%, then it becomes a problem. And only 2% result in permanent pain. And so the program we set up is taking that into account. We don't consider those that have a spontaneous remission and even those that are up to 6 weeks to be a problem. But those ongoing, they're going to be the problem and they're going to be the most costly patients, and that's where we take an intervention with our program. And the program the claim is to have less pain, better quality of life, and especially more autonomy and self-competence of the patients, and to have less hospitalization and surgery, have an early intervention against chronification, and the crucial issue is really timeline. The time is running, and if we don't understand that, that's more important than diagnosis, than any other finding. Time is crucial. And, sorry, I made a black screen. So certainly one of the key issues is reduction of sick leave costs. Now, the whole program is set as a network with primary care, with specialists, pain specialists in an outpatient treatment. It's done with centers of excellence in our society, located all in Germany. There is an interdisciplinary screening, diagnostic screening prior to putting the patient into the program. And the program is not a standardized program. It's an individual program and has just some standardized aspects. It's a multimodal, multidisciplinary program. And mandatory, there are some specialties included, which is pain specialists, it's psychologists and physiotherapists. And which is very different to any other way we have in Germany. Not the general practitioner, not the specialist is assigning the patient, but the insurance. Because the insurance is the only one who has data on sick leave. No one else knows. Patients go from one to the other, and none of us knows how long they have been off work. But the insurance knows, and they're identifying the patients and asking the patient, offering the program. So that's very different from another way to do it. And we have a different separate caregiving and management and documentation benchmark. So it's monitored, and the goal is prevention of chronification. Now, this is the whole concept, and what we really have at the moment, what I present to you, is these levels. We don't have admission by a general practitioner at the moment implemented, but we have admission by health insurance, and the patients undergo a diagnostic screening, multi-professional team, and if they're willing and are ready to do so, they go on the level 3, which is now patient comprehensive treatment. Also implemented is a second opinion treatment, which also goes to the same screening team. Now, inclusion criteria is a diagnosis, back pain in the broadest sense you could have, and the minimum of 4 weeks working inability correlated to this diagnosis. 4 weeks, because in Germany, after 6 weeks insurances have to pay, and before that, the employer is paying. So there it becomes really expensive for the insurances, and that's why 4 weeks of inability. No sufficient pain control and standard care, and the patient is motivated to participate, and no end of sick leave is foreseeable. An exclusion criteria is only malignant tumor, inflammatory rheumatic disease, and projected inpatient rehabilitation treatment, because that's been paid by another caregiver, by the Rentenkasse, and certainly lack of motivation. Now, lack of motivation is a key issue, because the patient undergoes a screening procedure. That means 1 hour of psychologist, 1 hour pain specialist, 1 hour physiotherapist. And the screening has to take place within 5 days after the patient has been offered the program. Within 5 days, well, either the patient is suitable or is not suitable. If not suitable, there's an alternative treatment proposed. If it's suitable, the patient undergoes a 4 weeks multimodal treatment. And this 4 weeks treatment means in these 4 weeks, 3 times a week, at least 1 hour psychology, 1 hour physiotherapy, 1 hour pain management. So at minimum 3 hours. Most of the patients have 4 or 5 hours, 3 times a day. And you can't do that if patients are not motivated, aren't really ready to take responsibility for themselves. The goal is to bring them back to work after 4 weeks. If that's working, it's fine. If it's not working, they can be added up to another 4 weeks. So the program is extended up to 5 to 8 weeks at maximum. And again, there's the chance to either go back to work or be unable to work. And the outcome should be sustained working ability. If it's bad, it's ongoing working disability. And there is a re-evaluation after 6 months. Now, the charming at the program is there's a global budget, no matter what we are doing. If you're successful, if you're not successful, if the patient doesn't return to work after 8 weeks, there's a malus, there's a minus of €250. Sorry, I always miss the right button. Is that the end of my presentation? No. But if the patient is successful and is able to work after 4 weeks of treatment and stays at work for another 6 months, not a single day sick leave, there is a bonus paid of €500 additional to the team. So this is paying for performance and not for procedure. And not paying for procedure means there is nothing done that doesn't make sense but is well paid for. And this is one of the key problems in our healthcare systems. Paying for procedure means physicians and healthcare carers do procedures and do treatments that are well paid but maybe ineffective. Paying for performance means we do anything that's of help. We do anything besides exorcism. We haven't tried that so far. But anything else can be done, and if it's only of help. So the screening team has to be pain medicine, psychology, and physiotherapy 1 hour within 5 days. And if the patient is ready to go and is suitable, the treatment has to start within another 5 days, which means within 10 days we have to supply psychologists 3 times a week, 1 hour, over 4 weeks. And we do this not only with one patient, which means you have to have a structure that is able to really handle these patients. Additional specialties according to what is needed. Now, I'm going quickly through that. What is really crucial in this program is it's not a patient running from one to the other over 4 weeks period, but the team is continuously having consultations, talking about the patients, where the patient is, and what should be done and what should be changed in the treatment. I think this is essential for the outcome. The treatment can do anything that's helpful. Certainly, psychological treatment, behavioral treatment is essential, but also is essential that we have a motivation, that the patient learns relaxation techniques, attentiveness, biofeedback. Continuous team conferences assure that it's really what the patient needs. And we have a common documentation platform. All of us see the same documents and see what's happening with the patient. And the treatment is regulated by the reports of the patients, not by what physicians believe patients have, but what patients report. And the documents are the standardized German pain questionnaire and the pain diary. And there's a re-evaluation after 6 months and external quality assessment. Now, the documents are these. I'm going quickly through that because you know these instruments. It's a standardized questionnaire, and there's a diary with pain intensity over the day, and that's done every day by the patient, and it's scanned, and there's 3 times the pain questionnaire again, after 4 weeks, after 8 weeks, after 6 months, and that's the material the patient has to do. A pain diary every day over 4 up to 8 weeks, and the patients do that. And that's the only thing what is relevant. It's not relevant what physicians believe how patients do, but relevant is what patients report. And that's really triggering the measures we take. Now, there's certainly a fact sheet and a data sheet that's reported. It's all controlled, and there's an external management. And the whole stuff is scanned. It's immediately put into the computer, and it's available. in all working places. Everybody can see the data. So what we see on a daily basis is pain intensity, maximum, minimum pain intensity. We see anxiety, we see depression, we see fear avoidance, we see everything that's relevant for treatment on a daily basis. So, and what we evaluate is patient-reported outcome. It's not physician-reported outcome. Now, what is the outcome? We have weekly reports, and I'm not going into detail to that because I'm going to show you figures. And we have a benchmark. All centers are compared to each other, to their effectiveness. How effective are their return to work after 4 weeks? How effective are their return up to 8 weeks? How many screening failures have they? So we have a benchmark in all our centers, and I'm now just going to share the results with you, because that's what I was asked to. But there are 41 centers included. Meanwhile, it's almost 6,000 patients, 24% screening failures, either because they have other diseases, they have tumors or whatsoever, or they're not motivated. And the result is that 86% return to work after 4 to 8 treatment weeks. Remember, after 3 weeks of working disability, in average days care, in normal care, only 35% return to work. In this program, 86% return to work. That means we have a 52% reduction in working disability, and this has been a scientific work done by the insurance with matched pair analysis. So from 172 days of sick leave, reduce that to 86 days. 86 days because these patients have been off work before they are included in the program. After 6 months, further improvement of quality of life because these patients learn techniques how to improve themselves. And now the ultimate question, can we save money? The average working disability cost is €55 in this insurance. It's only what they pay. They also pay additional social insurance costs that's not included in all this calculation. It's just what the insurance pays for sick leave, and that is a total of €9,460. 50% reduction means it's €4,370 they pay. And the program certainly is not for nothing. It costs in total, and on average, €3,700. That means the centers that have a higher rate of returners after 4 weeks save more money than those that were less. This is the average of the whole program, which means savings per patient in total after the program is paid is €1,000. So the insurance really makes money with every patient that's referred to this program. So generally we can say, yes, we can save money, but we have to change our habits. We have to change our habits. We have to look at timelines, not at long diagnosis, but really have early intervention, identify the right patients. We have to do multidisciplinary screening. We don't do it ourselves. We are not the all-potent scientists, but we have to do it together. We have to have team conferences. And really, what is most important, we have to rely on patient-reported outcome. Thank you very much.